Today I'm Dr. Al-Aboud Mohammed, cardiac surgery resident from King Faisal Specialist Hospital. Today I'm going to talk about the endovascular therapy for the treatment of the thoracic aortic disease. As an introduction, patients with thoracic aortic disease pose many challenges. Patients are older and present with multiple comorbidities. Additionally, the posterior location of the descending thoracic aorta requires a large thoracotomy incision with its own inherent morbidity. So the modern surgical treatment of thoracic aortic disease began in the 1950s when successful treatment utilizing segmental resection and graft replacement was first reported by Swan and Lamb, DeBakey, and Etheridge. And then thereafter, DeBakey and Cooley reported the first successful repair of an ascending aortic aneurysm using cardiopulmonary bypass. The cardiopulmonary bypass and commercially available tube grafts were the mainstays of our surgical practice for the next 30 years since that time. The improved diagnostic capabilities, surgical techniques, and perioperative care have resulted in improved outcomes even as the risk profile has worsened also. In an effort to limit the morbidity of these operations, endovascular techniques emerged as an attractive alternative. Originally advised for high-risk patients and following on developments directed toward aneurysms of the abdominal aorta, thoracic endovascular stent graft technology has rapidly evolved. The thoracic stent graft applications have been expanded to the treatment of multiple pathologies, including acute and chronic aortic dissections, the penetrating atherosclerotic aortic ulcers, and the thoracic aortic trauma. The first homemade thoracic graft was implanted in the descending thoracic aorta in 1992. And the results have steadily improved and long-term durability have been encouraging. However, the necessity for the long-term follow-up remains. Here is a French thoracic aortic stent grafting experience over the 2-year period from 1999 through 2001. A total of 166 thoracic aortic stent grafts were placed in 29 centers with no center performing more than 15 cases, and most centers inserting 5 or less grafts in the 2-year period. The experience analysis that they came with the overall mortality and major complication rates were significant at 10% and 29% respectively. The type 1 and type 2 endoleaks occurred in 16.3%, and patients who had proximal descending thoracic aortic coverage, which is 23 patients, at 26% had a type 1 endoleak. And there is also early results from the Society for Vascular Surgery, endovascular treatment of thoracic aortic aneurysms. It is a multicenter prospective non-randomized phase 2 study of the GORTAG endoprosthesis was reported at 17 sites and compared the results of stent graft repair of descending thoracic aortic aneurysms in 140 patients with the results of open repair in 94 patients. Strict inclusion and exclusion criteria were defined in an attempt to ensure compatibility of both groups. Follow-up computed tomography scans were obtained at 1, 6, 12, and 24 months. For stent graft patients, operative blood loss, renal failure, paraplegia, and mortality rates were all significantly less than for the open repair group. Interestingly, the stroke rates were approximately equal in both groups. ICU stay and total hospital stay and time to return to normal activity were approximately 50% shorter for the stent graft group than for those with open repair. Although stent graft patients had reduced aneurysm-related mortality out to 2 years, 3% versus 10%, all-cause mortality was similar between groups at 2 years follow-up. So the thoracic, beginning with the thoracic aortic aneurysm, approximately 50% of all thoracic aortic aneurysms are located in the descending aorta. And these aneurysms commonly arise at the level of the left subclavian artery and are often atherosclerotic in nature. The thoracic aortic aneurysms have an overall 5-year rupture risk of 30%. However, in an ever-increasingly elderly population with multiple comorbidities, endovascular repair has become increasingly attractive, especially for patients with favorable anatomy. Coverage of the left subclavian artery to create a satisfactory proximal landing zone has been frequently employed with few complications. The preoperative left subclavian to carotid transposition needs to be entertained, and patients considered at high risk for paraplegia should receive a spinal drain preoperatively, and hypotension should be avoided as explained by Dr. Abdurrahman. Perhaps the greatest impact of this endovascular technology has been on the treatment of thoracic aortic dissections. The acute descending thoracic aortic dissections are generally managed medically with control of blood pressure. However, in complicated descending thoracic aortic dissections, intervention is needed and has been shown to improve outcomes. The preferred intervention today is by TVAR, thoracic endovascular aortic repair whenever possible, rather than by open repair as observed in complicated acute type B aortic dissections. The complicated acute type B aortic dissections complications are including persistent or recurrent pain, uncontrolled hypertension despite full medication, early aortic expansion, size expansion, and malperfusion and signs of rupture such as hemothorax and hematoma. In regards of the traumatic aortic transections generally occurs at the level of the thoracic aorta in the region of the ligamentum arteriosum, just distal to the origin of the left subclavian artery. It is usually seen with rapid deceleration injuries that often leads to concomitant head, neck, and chest trauma. In contained transections, endovascular repair has significantly lowered morbidity, 42.4%, and mortality of 7.2%, compared with the open repair, 50% and 23.5%. Even among the younger patients population, they have the same results. The penetrating aortic ulcer and intramural hematoma, in this regard, it's characterized by penetrating aortic ulcers is characterized by an ulcerated atheromatous plaque that extends into the aortic media, whereas an intramural hematoma is characterized by hemorrhage within the aortic wall without a clear intimal disruption. Intramural hematoma likely occurs from hemorrhage into the media from the vasa vasorum. Indications for intervention include rupture, saccular aneurysm, or symptoms. The principles of TVAR is the exclusion of aneurysm or dissection with the use of self-expanding covered stent. Placement of this stent is through the femoral artery, and in most cases under imaging guidance, and requires an adequate landing zone for the stent graft proximal to the aortic lesion. As complications, the complications commonly are the endoleaks, which is defined as leakage of blood into an aneurysm sac after stent graft placement procedures, and are the most common type of endovascular complications, which may progress to aneurysmal ruptures. And second, we come to the neurological complications, include permanent, complete, or incomplete paraplegia, reversible spinal cord ischemia, transient stroke, and permanent stroke. Careful patient selection together with a strategy to reduce embolization before and before endograft deployment may be beneficial. And this is come to the pre-op planning for those patients. Type 1 endoleaks occur at the proximal or distal attachment sites and signify a failure to achieve a hemostatic seal at these sites. The type 2 endoleaks denote a communication between a branch vessel and the excluded aneurysm sac, and are commonly seen with the back bleeding intercostal vessels, lumbar or inferior mesenteric arteries as a common branch. Type 3 endoleaks occur at graft-to-graft junctions, and the type 4 endoleaks are characterized by increase in aneurysm sac size and the absence of an identifiable endoleak, variously referred to endotension. So those are the 4 types of endoleak. And here is a short video which show or explain the endoleak.
Endoleaks after endovascular aneurysm repair. An abdominal aortic aneurysm can be treated by a minimally invasive procedure that places a stent graft inside the abdominal aorta. The stent is designed to protect the integrity of the aortic wall. The aneurysm is not physically removed. While the treatment offers certain benefits that open surgery does not, including faster recovery, less complications, and less pain post-procedure, placement of a stent creates potential for developing an endoleak. An endoleak occurs when blood continues to circulate in the aneurysm sac. To reduce the risk of aortic rupture, continued monitoring for endoleaks is necessary following stent placement. The 2 most common endoleaks are known as type 1 and type 2. Type 1 endoleaks affect approximately 1 to 2% of patients and occur when an ineffective seal at the top or bottom edge of the stent allows blood to flow into the aneurysm sac directly from the aorta. This is usually due to stent migration, and occasionally the stent can completely detach and fall into the aneurysm. The treatment for this complication is either the introduction of a new stent or the repair of the aneurysm via open surgery. Type 2 endoleaks are the most common, affecting between 10 and 15% of patients. These leaks are due to retrograde or reverse direction blood flow entering the aneurysm sac from small lumbar arteries and/or the inferior mesenteric artery. Type 2 endoleaks may resolve themselves, therefore close monitoring precedes further treatment options. The remaining 3 types of endoleaks occur more rarely. Type 3 leaks occur when there is a gap between the main body of the stent and its smaller leg component, which can develop over time due to progressive angulation. These gaps are closed with glue, the interposition of another stent, or the dilation of the existing stent to improve its position. Type 3 leaks are seen less frequently due to newer generation stent graft materials. A type 4 leak is transgraft hyperfiltration, where blood slowly filters through the walls of the stent into the aneurysm sac. Type 5 endoleaks are characterized by continued pressure and growth of the aneurysm sac without any definable endoleak. For many, endoleaks are a source of confusion and anxiety. However, with education, proper treatment, and follow-up care, stents provide an appealing alternative to open surgery.
So as here I can finish the knowledge about the TEVAR in terms of management of the different pathologies of the descending aortic descending aorta. Here is there is a video of technical part of TEVAR. I'm not sure if there is any question before we begin this. This is a DBAC Institute for Cardiovascular Education and Training, which been uploaded in January 2019, explaining the TEVAR pre-planning and intra-procedural techniques and the some knowledge about it.
So Dr. Bavari is one of our favorite vascular surgeons here at Methodist, and he's going to be talking about TEVAR.
Hi, good morning. I'm Charu Bavari. I'm one of the only vascular, not cardiovascular. So I'm sitting in August's company back there. And these are the people actually who have trained me in the past, Dr. Reardon, and then now getting more training from Ross and Tom, and a great group to work with. But the mouse is not good to work with, yeah? Oh, there it is. Okay, so my topic is THOR. I mean, I'm like taking a big bite to chew because we have experts sitting in the back out there. I'm just going to talk about what I know a little bit about. So we'll talk about the history of THOR, a little why we do it, what's the pre-procedure planning, what imaging is involved, what do we do at the procedure, how do we follow these up. We have some newer, more exotic and indications, and then some conclusions of what to do or what not to do. The indications, the most common indication is thoracic or descending thoracic aortic aneurysm, traumatic aortic transection, which is a grade 2, 3, or 4, type B aortic dissection, penetrating aortic ulcer, intramural hematoma, and then the thoracoabdominal aortic aneurysm. Usually it's a multi-component complex repair, not just a single graft, right? There is a lot of pre-case planning that goes in because one, endovascular therapy has dramatically decreased the number of people that can be number of people that can be offered treatment now. So someone who will probably code with a haircut will probably do okay with a little local and putting in a graft of their aorta sometimes. Straightforward cases can actually just be that. Sometimes they are pretty straightforward if you choose them wisely. Difficult cases can be disasters, of course, and make sure we anticipate potential complications. Access issues, need for the conduit, patient comorbidities, cardiac comorbidities, stroke comorbidity, etc. And then risk of paraplegia is a finite complication of this procedure. So with prior aortic surgery or left subclavian artery origin involvement and coverage of that, chronically occluded the internal iliac arteries, and then coverage of T12 to L1 segment of the aorta where the intercostals come off. And we'll come to that as well. I don't see these images up here. Anyway, so it's increasingly important with complex cases to be prepared for this. You need proper imaging systems because you cannot see you cannot fix what you cannot see. You need a lot of array of wires and catheters and adjunctive things on your repertoire. You need the OR. We don't have the cath lab. We usually have an OR crew which is pretty capable of doing this with us. Some facilities bring the OR and cath lab together. I think that's a paradigm with the TAVRs for sure. You need to be skilled for this. It's not a chip shot every single time. So we have to have maneuvers to get ourselves out of trouble as well. Plan for whether you need to revascularize the left subclavian artery or not. And there are specific indications. And then perioperative spinal drainage is like the absolute standard now of care. The anatomic issues involving suitability, right? So you have to have a proximal and distal length of more than 20 millimeters, at least for a landing zone in the thoracic aorta. There shouldn't be a lot of aortic, if there is a lot of aortic thrombus, the seal may be an issue. Access sites are always a problem. You need a big sheath to go in with a big device. So an access vessel of at least 7 to 8 millimeters is needed. Sometimes you may need to put a conduit. There could be occlusive disease in those vessels. There is a lot of tortuosity sometimes in the iliac arteries. There could be concomitant common femoral disease. So you might need to repair the femoral artery and then put something through. And you need, I don't think it's 25%, it's less now with the smaller caliber, low profile devices, but you may need to do an iliac conduit to get your device in sometimes. The tortuosity of the aorta itself could be a problem. And then the cerebral arteries coming off the aorta going into the circle of Willis could determine your stroke rate post-procedure. More often than not, we've almost always had, almost surely nowadays do percutaneous access with pre-closed technique, but you may have to do an occasional cut down in the end or even in the beginning as a planned procedure. Some surgeons actually prefer to do a cut down to begin with, so you have control on the vessel. It's not wrong, it's just preference sometimes. It just makes it easier afterwards. Consider a conduit, like if you're doing a large device, so therefore you need larger access in the artery. Then open iliac conduit is usually a 10 millimeter graft with a retroperitoneal exposure, and that gives you enough length to go through and intervene on pretty much all kinds of device sizes. Sometimes we have an endoconduit with a stent graft placed inside the artery through which you can go through. That is if the artery is very calcified and you might need to intervene. Imaging is the key, where you have to have a sure shot, good quality cross-sectional image. You may not have all the other tools like the M2S, THORACIC, OSIRIX, but we have to know what's the right angle. We have to know what's the right length. You have to make sure the tortuosity is taken out. I don't personally use the M2S system, but some people swear by it. These are good tools to have if you do, but if you don't, it's not the end of the world. But if you can, it'll make life a lot simpler for planning. So proximal zone, distal landing zone, I cannot see that. So based on the CAT scan, this is all made nice and fancy for us, right? Keep in mind, sometimes tortuosity of the vessels, you don't see much in the axial, but if you have a reconstruction, you'll see it much more. Using an IVUS is really, really crucial, almost like standard of care in thoracic dissections, where you have to know whether you're a true lumen or not. Otherwise, a TVAR can just make a good case into a great case. So you have precise measure. So you have to precisely measure the aortic diameter and length, make sure you're in the true lumen, especially in trauma, ruptures, iliac axis, origin of the arch vessels, visceral vessels. It takes a little training for the eye to look at and interpret an IVUS, but with experience, actually, it's a solid tool to have and to know. So usually this is for an aortic aneurysm, right? So you have bilateral common femoral axis. You do an arch aortogram. Make sure that it's an LAO projection because the arch goes back and to the left. It doesn't go this way. So make sure the II is angled properly. Anticoagulation is something I routinely use on all these endovascular devices because you have huge sheaths going up in the iliacs. You're almost completely occlusive at that point. Curved Lunderquist wire is the workhorse for a TVAR, which is a pretty stiff, we call it the coat hanger wire. I've stole one for my wardrobe as well. Use the IVUS when you have to have it. Stent graft deployment, usually on the way out sometimes for a iliac on a stick situation that you might have, hopefully not. And then post-implantation, post-dilation, use that with caution in cases and use it never in dissections. Remember this, the word is never. Never say never, but never dilate in a dissection because it will turn a good case into a great case. So a case example is a 69-year-old guy who's got, where'd that go? He has an aortic aneurysm about 4 centimeters, but he's getting bigger now. He's got severe hypertension. He comes in with this is not my slide, but typically this is a great illustration of how to measure these things and how to plan for this. So you look at the proximal landing zone, distal landing zone. This looks like almost like a type 3 arch where all the great vessels come off below and it still keeps going higher. Look at the distal landing zone, look at the calcium, and gives you a lot of clue. So the planning here is, I trained here, and then Alan Lumsden, our chairman, he used to tell me, or he still tells me actually, that nothing of what you do for an endovascular case should be a surprise in the operating room. So you have to plan for this. You should rarely have anything that's going to be I didn't see this before, because we see a lot of things on CAT scan now. So planning. Usually TVAR patients can be actually discharged the first or second day, and then they get a 3D CT within 30 days of the procedure. Typically, you don't have to repeat it for about a year almost if you have a good result, because endo leaks is something that you don't actually get too often in TVARs. In EVARs, it's a big bane of our existence for sure. Pitfalls, so sizing errors, undersizing, oversizing can have serious problems. Insufficient length or quality of the fixation zones, not placing the endograft proximally enough can be a problem. And then sometimes there is reluctance to go right up to the origin of the subclavian, or even say, okay, I'm going to cover it and then revascularize it, right? So it takes about half an hour more for the procedure. But we have seen patients who've not had this done because the surgeon didn't want to add some time. That's bad. Make sure you anticipate all your access problems, because access site problems are the case goes great, but then the access site becomes a big issue afterwards. A bird's beak is where the aorta is pretty angled up pretty quick, acutely, and then the bottom portion of the stent graft doesn't oppose to the aorta, so it remains this way. And then over a period of time, this can have a leak, a type 1 endo leak, or the aorta can get compressed around that, so that becomes a problem. Great vessel involvement in thoracoabdominal or thoracic and abdominal aortic aneurysms. Typically, you don't have to revascularize the subclavian artery, not routinely. You can get away with that, especially in trauma. We can cover it and get away with it. The problem is here. There is an absolute need in these conditions. So you have a patent Lima bypass. Every cardiac surgeon in the hospital will come after my neck if I do this. I go after my neck first. But if you have a patent Lima bypass, you have to revascularize subclavian artery. If you have a dominant left vertebral artery, you have to revascularize. If you have a left vertebral artery which terminates in the brain and then the right vertebral is dominant, then remember, even though the right vertebral is dominant, you still need to revascularize the left subclavian. If the left vertebral comes off the aortic arch, is not an absolute contraindication. It's absolute indication. But if you have a stenotic vertebral artery, if you have a fistula, a dialysis axis, again, I wouldn't say this is absolute because you can always have a catheter and go for a new fistula on the other side. That's not life or death. But if you're doing a life-saving operation, that fistula may not be the only thing to do. So a carotid subclavian bypass, usually with prosthetic material, or you can transpose the subclavian artery. It's easier said than done because you have to dive in a hole, make sure the vertebral lemma come off, and then take the subclavian off there. The zone 1 arch involvement, which is right at the takeoff of the left subclavian, you may need to do a carotid subclavian bypass and then cover the whole portion there. Sometimes you need a lot of hybrid procedures where we actually work really well with the cardiac surgeons at our hospital, where we do a deep branching from the ascending and then cover the rest with a good landing zone there. Now with new endografts coming in the market, you can actually have branch devices. You can have a branch going up into the subclavian artery, so that negates the need for a carotid subclavian bypass. They're all complete systems. Gore actually is the only one right now who has an FDA approved device. I'm sure there are multiple people in the market coming up with something more. So this is one tool to know and how to use. Big complications to remember are stroke, paraplegia, visceral ischemia, migration of the device, and then access site complications. So analysis of stroke, it's pretty significant. It's about anywhere between 5 and 25% of the time. And typically it's where the zone 1 aortic arch is involved, where you have severe athermatous disease in the aorta, and where you cover the left subclavian artery. The neurologic complications from the Eurostar registry, actually it's about 0 to 6% in TVAR, but it's about 12 to 14% in open. And if you have a prior history of infrarenal aortic repair or replacement, if you cover more than 20%, I'm talking about spinal ischemia, I'm so sorry. So if you have, incidence in TVAR for spinal ischemia is about 0 to 6%, and open surgical procedures up to 14 to 20% actually. And if you have a prior history of infrarenal aortic repair or replacement, because you knock those collaterals off, if you cover more than 20 centimeters of the descending thoracic aorta, if you use more than 3 stent grafts, which is obviously more than 20 centimeters, and if you cover the left subclavian artery, if you have an occluded internal iliac artery, that your risk of paraplegia goes high. And the logic is here. The vertebral arteries go and meet the basilar artery. Before they meet the basilar artery, they send 2 arteries down, which becomes the anterior spinal artery. That's one critical artery for the brain, for the spinal cord proximally. The next big one is the intercostals coming off, and the artery of Adamkiewicz coming off at about T12, L1 level. So coverage of all that aortic segment can become a risk for spinal ischemia. This is a great paper actually from the anesthesia and analgesia, which I never expected there. But I feel kind of sorry we didn't come up with this thing. But I think Dr. Athanasiou will talk more about that. Essentially, you want to keep the spinal cord perfusion pressure right. And so you maintain the MAP, you keep their CSF pressure low, make sure you give them fluid boluses, make sure you resuscitate them properly, supplemental oxygen. That's the 4 things, and obviously Dr. Athanasiou will tell you more about that. Follow-up is we do CTA per protocol about yearly, and then every 2 to 3 years. Endoleaks are really less common than EVAR, and then secondary interventions are few, except for the bird beaking, which becomes really bad. I would say endovascular therapy has dramatically expanded treatment options now for people who erstwhile would have been bad candidates for descending aortic problems. Evolving technology and refinement of skill set of physicians will help gain more access to these cases. I did not go into the branched endografts and all the fancy fenestrated stuff that we do, because I think just basic TVAR is what this involves. And then remember, perioperative stroke and perioperative paraplegia will remain the main complications to watch out for. And I thank you so much.
So at this moment, I think to take a home message, TVAR is the preferred choice of intervention for patients with descending thoracic aortic conditions and insufficient seal zones. Safe preoperative planning and suitable device sizing are important to obtain good results and reduce complications and complication rate. The TVAR has improved to be safer and has the potential to expand treatment choices to include ascending and arch pathologies in the future. And thank you for listening. And if you have any questions or discussions or any comment.
دكتور فهد.
ايوه تفضلي.
دكتور هو قال عن انه you can cover the subclavian artery and you can get away with it. So my question انه how frequent you cover subclavian without doing bypass between carotid and subclavian?
Okay, thank you, Dr. Zainab, and thank you, Dr. Mohammed, for your nice presentation. Since I started on our center, maybe with the vascular surgery, we had more than 100 cases of traumatic aortic disruption, just distal to the subclavian. So almost 99% of all those cases, which are around maybe we reach 40, 42, they are all, we cover the subclavian. So why is that? Majority of those patients are young because they come after RTA. So covering the subclavian is not a big issue if you have a good collateral, unless you have a contraindication like what we mentioned in the video Dr. Mohammed showed. But the problem with covering the carotid, so if you are going to have, if there is no proximal landing zone, and you have to cover the carotid artery, which the left common carotid, at that time you have to do a carotid bypass. I hope that I answered your question.
Okay, thank you.
Dr. Mohammed, any other question?
I have two questions, if you don't mind, Dr. Fahad. The first question is, in the abdominal aorta, when you cover it with an endograft, if you don't use the tailored one with the branches, how are the branches get perfused? How do they get perfused? And the second question is, in patients with aneurysm due to genetic disorders, is endovascular still a preferred technique for repair, or open is better?
Okay, thank you, Faisal, for your questions. For the first question, if you have an infrarenal aortic aneurysm, so you will have a bifurcated graft, which is the main body covering the infrarenal aorta, and two limbs going to the both common iliac. Sometimes the aneurysm extend down to the even external iliac. So some people, they use what we call IBD branch, which is the iliac branching device, which you can use to perfuse the internal iliac, especially if you have to cover both internal iliacs. So you have to revascularize one of them. This regarding the infrarenal. For the suprarenal, if you don't have a branching device or fenestrated device, we use what we call a chimney technique. Chimney AVAR is you are putting stent grafts, which is balloon expandable, inside the superior mesenteric artery and the renal artery and the celiac artery. So you have to have both 4-branch chimney. Then you cover the aneurysmal part. If you need to go down to the iliac, so you have to use again another graft, which is a bifurcated iliac graft. So you take your inflow from up. So you have to have both axes, from the brachial and from the femoral. Regarding the other question, معلش تعيده مرة ثانية لأن أنا ضيعت.
My second question is aneurysms that are caused by genetic disorders like Marfan.
Yeah. As you know, that Marfan disease is usually they will get even after open repair, they get dilatation of the proximal or distal part of the normal aorta or of the natural aorta, not the graft. So ideally, yes, open technique is better, but sometimes with other complications like dissection or pseudoaneurysm, you can use endovascular technique, at least as a life-saving procedure. And you keep follow the patient with serial of CTs, like every 6 months in the first 2 years, then annually. And you see, if you start to have endoleak, proximally or distally, you have to fix it with what we call a cuff graft. Or if the patient is low or moderate risk for open procedure, so you have to fix it by a Dacron graft.
Thank you, Doctor.
You're welcome. So did you imagine the chimney technique, or is it clear, or we need to share like photos?
Actually, I would need photos, but I will look for it.
Great. Dr. Muhammad, any other questions?
I have no questions. I'm not sure if the others have questions. Okay, so I think here we finish our presentation regarding the EVA.
Okay, thank you. There's any other question or?
يعطيك العافية محمد.
الله يعافيك.
Thank you, Dr. Muhammad. Thank you, Dr. Fahd. I think we can proceed now to our last session. Aortic